Good evening, everyone, or good morning, or good afternoon, I guess, depending upon which part of the planet you're joining us from. Welcome to this evening's webinar presentation on common reasons for medical denials. My name is Gary Crump. I'm the Director of Medical Certification here in AOPA's Pilot Information Center, and I'm joined tonight by my co-host. Many of you recognize the name Jonathan Sackier and his delightful accent from across the pond. Jonathan is joining us tonight from the beautiful city of Montreal. Jonathan, good evening.
Good evening, Gary, and good evening, everyone out there in AOPA land.
Once again, thanks everybody for joining us tonight. Right off the bat, I want to also say thanks to Joanne Wilson, who is one of our senior medical certification specialists. Joanne will be taking some of your questions tonight and responding to them during the course of the webinar tonight. So keep those questions coming in. We probably won't be able to answer all of them, but just to remind you, we do have an entire department of medical certification specialists here in the PIC that are dedicated to answering medical certification issues and work with members to alleviate the issues that we're going to talk about tonight, as a matter of fact. So if we don't get your question answered, by all means, give us a call and we'll help you out with that. So let's get started. Always when we do these medical webinars, we have kind of a game plan about what we want to do, but for those of you who have joined us on previous webinars, you probably recognize that we tend to wander off course a little bit and talk about some of the ancillary issues that may be coming up or may be arising out of the topic and the slide that we're talking about. But miraculously, we always manage to get back on track, and hopefully that will be the case tonight. So tonight, even though the title is Common Reason for Medical Denials, here's kind of a menu of what we're going to talk about tonight. We will discuss a little bit about the process, the FAA's issuances process, how they do things, why they do the things they do. We'll talk certainly about your AME and the options that the AME has in his or her responsibility when you show up for a medical examination. We'll talk about an important aspect of the things that pilots don't always do that they should do prior to their medical examination. And then we'll talk about, as a repercussion of the things the pilots should have done but didn't do, we'll talk about the things that FAA can do based upon what the pilot does or doesn't do. Then we'll talk about things that will prevent the FAA from doing what they do. Don't get confused. We'll straighten it all out. And then finally, we'll talk about some of the common medical conditions that we deal with here in the Pilot Information Center that mess up what we call playtime in the sandbox, that can disrupt the smooth issuance of your medical certificate. Let's talk a little bit about the FAA certification statistics. Right now, obviously, there's a lot of angst with the FAA, as most of you know. AOPA has been involved in a multi-year endeavor to decentralize and deregulate the medical certification process. And hopefully we're getting fairly close to achieving success with that, because in the environment we have in government right now, with the FAA not having been funded with a steady funding stream for probably 5 or 6 years, with the absence of an FAA authorization bill, a lot of services that the FAA would normally be performing in the course of their responsibilities for maintaining aviation safety are not being done as efficiently as they should be, and that is certainly the case with the medical certification process. On average, about 450,000 FAA physical examinations are done every year. And about 99% of the pilots who apply for a medical certificate are ultimately issued a medical certificate. In fact, the vast majority of those are issued by the AME at the time of the medical examination. However, it's not 100%. So initially, the FAA will deny an airman in about 3,000 cases, 3,100 cases. And those are initial denials for a multitude of reasons that we're going to talk about tonight. The final step in that process that gives us that 212 final denials number simply means that the FAA issued a denial and then asked for additional information, and the pilot just chose not to provide that information and just packed it in and went and bought a boat or flew with another pilot. So when you look at the numbers, 212 500,000 is an extremely small number, but in order to get that 99.7% of airmen issued, sometimes you have to jump through a lot of hoops and to satisfy the FAA that your medical condition is safe. The world of special issuances is increasing also, because as the FAA is able to medically certify more and more pilots, they use the discretionary special issuance process for more and more medical conditions. And we've done numerous webinars in the past just on special issuances and those 15 mandatory conditions that are specified in the Part 67 medical regulations, and then a multitude of other medical conditions that, although not specifically disqualifying, do require special issuance because of the nature of the potential for the progression of the disease. And we'll touch on all of these things as we get a little bit further down the road here. But I'm going to turn it over to, actually I'm going to turn it back to me here right now. So we talk about some of the stumbling blocks and some of the things that your AME, your Aviation Medical Examiner, has the option to do when you go in for a flight physical. Obviously, everyone now has to complete the online medical application, MedExpress. That's been a mandate here for several years now, and we've, in fact, this week I've talked to a number of pilots, rusty pilots we're calling them, who have been out of flying for many years and have never completed the online application. So there's a little nuance about completing the application online, but once that application is submitted and you present the confirmation number that you receive either by email or when you print out a copy of the application, that confirmation number you take to the medical examiner, and the AME's office actually enters that confirmation number into the certification system and pulls up the exam that you have completed online. And at that point, you and the AME ideally review the application, and AME is probably going to ask you some appropriate questions, specifically now by certification policy regarding sleep apnea. The AMEs are asked to question all applicants about their risk for sleep apnea. Do you snore at night? Does your partner complain about your snoring? Do you have any daytime sleepiness? And then you're basically put into one of about 6 different buckets. Either you're not at any risk for sleep apnea, or if you fell asleep in the AME's office waiting for your flight physical, you're put into a different bucket. And based on which bucket you're assigned determines how the AME will handle the examination going forward. So that's one example. So the AME then conducts the examination, document the findings. This is a real important part of the process, and we'll be spouting out some little nuggets of information, little tidbits here to help you out along the way. And I would say this is the first one. Block 60 is actually a block on the examination side of the application that the AME is doing. It's actually the examination part of the physical process. And any findings that the AME observes during the course of the examination, or if the AME or the pilot is reporting some type of medical condition that hasn't been reported before and you walk in with your paperwork, the AME can use a free-form text field in Block 60 to type in anything that he or she observes or any explanations that are necessary. And the FAA relies very heavily on this Block 60 because this is kind of a shortcut for the AME, because sometimes, I mean, the application is kind of cut and dried, and if you don't provide good documentation, or even if you do, but there's a question about it that needs clarification, the AME can very effectively use Block 60 to explain to the FAA the rationale for his or her decision to issue or defer your application. So call that tidbit number 1, Block 60 on the examination side. And then, as I said, 95% of medical examinations result in the issuance right on the spot of a medical certificate. So that's for the vast majority of us walk out the door and never have any other problems with it. The AME also has the option to deny a medical certificate or the issuance of a certificate if there is a clear evidence of a history of one of the mandatory disqualifying conditions. We see very, very few AMEs actually issue a denial because the AME is an agent, a designee, just like a pilot examiner who's authorized by the FAA to act in the FAA's behalf. And even though they are allowed to deny a medical certificate, it requires an awful lot of documentation, a lot of paperwork, and the FAA encourages AMEs not to bother with issuing a denial, even if there's a clear disqualification there. They'll say, defer to the FAA and let them make the decision. So those are the options that the medical examiner has during the conduct of the exam. And again, we'll talk about each of these as we get a little further down the road. Okay, Jonathan, I'm going to turn it over to you.
Well, thanks a lot, and again, good evening, everyone. I just want to make a general point, first of all. Your AME is a human being just like you, and the people at the FAA are human beings, and many of them are pilots, and many of them really don't want to be doing bad things. The actions they take are not ad hoc, they're not spurious, they're well thought out. And I want to tell you all one thing for a fact. If you've got a problem, if you've got an issue with your medical, there is one surefire way to make sure that things will not go in your favor, or at least go expeditiously, and that is to be nasty. And Gary will attest to this. We get a lot of correspondence from people who are upset, and I get that, but being angry and, quite frankly, being abusive is an extremely efficient way to not get what you want to happen. So I just wanted to throw that out. And also, the actions FAA takes are, as I say, based on data. One of the questions that has popped up, and there's a lot of questions, keep them coming. And by the way, things that don't get answered today, we will try and answer within the online mailbag that we send out once a month. So we'll try and get to these questions. But just as an example, there's someone who's angry that there are certain drugs, and I am a doctor and I prescribe lots of medicines that are FDA, Food and Drug Administration approved, but FAA doesn't approve. That's because there is not enough data. There are not enough data to show safe use in pilots. And the example that this pilot has asked about is a drug called Tickersin, or the generic name for that is dofetilide. Dofetilide is used to treat a condition called atrial fibrillation, when the heart is not beating properly. And whilst you can get certified on an atrial fibrillation medication, Tickersin is a drug that has side effects such as potentially making you go unconscious or having a very bizarre heartbeat. Not something that you want to happen to someone who's controlling an aircraft. So things for the pilot to do. You need to do some homework before your physical. Number one, is there anything to report on MedExpress? And how would you know there is? Simple matter. Keep a diary. Every time you go and see a doctor, have a file on your iPhone or your tablet or your computer, or if you're old-fashioned, just have a paper file. Note the date that you saw the doctor, who you saw, why you saw them, and what was done. If any new medication was prescribed, check that that medication is, as we were just discussing, acceptable to FAA. Answer everything truthfully. The truth will set you free. And not answering a question truthfully can get you into trouble. So document everything, document medications, but make sure that you've checked that they're approvable medications. And if a new doctor has prescribed something and they hadn't thought it through that you were a pilot, or you can direct them to the AOPA database of approvable medications, you can always say, is there something else? Because that isn't on my magic list. Take stuff with you to the doctor so that you don't have to come back to them. An example of that would be if you've had, like I had in the past, laser eye surgery. Make sure you have the 8700 visual form completed and presented to the doctor at the time of your appointment. Have something for the AME to work with. Anything. I also had a screening colonoscopy just for good health. I made sure that I brought the report and a letter from the treating physician. My AME looked at it and said, I don't even need to include this. Thank you very much. It gives the impression that you're on top of things. Don't make your appointment for the AME at the last day of the month that your medical is still applicable, and certainly not at the end of that day. One year I had a urinalysis test and it showed some potential blood in the urine. Well, rather than defer me, I have a very nice AME who said, let's send the blood off to the lab, let's put it under the microscope, let's see if there's any red cells. There weren't. I waited around a few hours, actually till the next morning, and I had my certificate. So plan to make life easy for your AME. Less is better than nothing, but enough is better yet. Get the volume of documentation correct, and if you don't know what to take for a given medical situation, ask AOPA's Pilot Protection Services. That's why everyone should be a member. I am. Back to you, Gary.
Thanks, Jonathan. I want to reiterate a little bit of what Jonathan was just pointing out. When you're reporting something new, we get calls every single day from pilots who misread question 17 on the medical application. That question asks, are you currently using any medications, prescription or non-prescription? And for some reason, pilots don't read that question carefully, and they will report a medication that they have not taken for years. We had one airman just today, who was at one time was taking a neurologic drug. It's actually an anti-seizure drug called Neurontin, and he was taking it for some unrelated condition, but reported that as currently being used on his medical application, and he got a denial as a result of that. So then he had to go back to his treating physician, as everybody does, to get verification that this medication is no longer being taken, hasn't been taken for a long time, but you also have to document why you were taking the medication in the first place. So those little slip-ups can come back to haunt pilots in a big, big way, because once the information is on the application, the FAA has to respond to it, and sometimes it can get really messy, because then you have to go back and get multitudes of medical records to document, number one, why you're on that medication and the date it was discontinued. Again, the issue is document, 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 because if the AME has nothing to work with, as Jonathan said, it makes it really hard for the medical examiner to make a certification decision. So you make the AME's job easier, and it makes your life easier as well. So thanks, Jonathan. Good follow-up on that. So let's get into some of these medical conditions. Jonathan, let's talk about hypertension. This is still one of the most commonly asked questions, and the condition that causes the most angst among uninformed pilots, because they have to start taking blood pressure medicine. They think their flying days are over. If you were flying in 1982, you had a reason to be concerned about it, because even then, FAA was just beginning to feel comfortable certifying certain types of blood pressure medicines, primarily diuretics, the medications that make you pee. And that was the only classification of drugs for many years that the FAA allowed. Now, just about everything. So, Jonathan, take it away, and let's talk about hypertension and what it does.
Well, first of all, and those of you who've heard me before will start rolling your eyes, doubtless, just like I talk to my kids and they roll their eyes when I tell them something. Hypertension is rampant in these United States. Heart disease is rampant. And the best way to avoid the aggravation of dealing with the FAA, oh, and by the way, avoid having the sequelae, the unpleasant sequelae of having high blood pressure, is avoid getting it in the first place. The best way to avoid getting it in the first place is A, choose your parents. Well, you obviously can't do that, but what you can do is eat a healthy diet and exercise. Do not smoke cigarettes, and have your blood pressure checked with regularity. There are hundreds of people on this webinar, pilots one and all, and I bet I flew an approach today, and as I'm flying that approach, I'm thinking to myself, what are my speeds? What's my VFE? What's my VNE? What's VSO? I know those speeds. I know those numbers. I wonder how many of you know your blood pressure. So know your blood pressure. What is hypertension? Hypertension is when the two numbers you see, like 120 over 80 or 170 over 110. The first is the pressure when the ventricles, the main chamber of the heart, is contracting. That's called the systolic blood pressure. And then the other is the relaxed state, the resting pressure, if you will, the diastolic pressure. And once that goes over a certain number, and it's a little bit age and sex dependent, you have hypertension. FAA has certain parameters. But basically what's happening is the blood vessels in the body, the tubes through which the blood flows, become unresponsive to pulsatile flow. The pressure in them rises. Sometimes there is a blockage within vessels, and the heart has to work harder to push oxygenated blood around the body. And you end up with problems. You end up with heart attacks and strokes and kidney failure and digits, toes and fingers potentially becoming starved of blood and maybe becoming gangrenous. Hypertension is bad, bad news. As Gary said, there's a whole bunch of different drugs that can be used to treat hypertension. The best way to treat it, as I said, is don't get it. If you do get it, change your life. It's a huge, huge warning bell that you've got problems and you need to lose weight and exercise more and eat more healthfully. But if you need to take medications, breathe a sigh of relief. The vast majority are approvable by FAA. There's only a couple that aren't, the so-called centrally acting drugs. So Gary, do you want to talk a little bit about what one has to do when one sees, and we've already had some questions popping up about hypertension, what do pilots have to do if they are diagnosed?
First of all, as Jonathan said, get it treated. In years past, probably 5 years ago, the FAA required at your first reporting of a blood pressure medicine, they required basically a modified cardiovascular evaluation. You had to have an EKG done. You had to submit some blood work. They wanted to see your cholesterol. They wanted to see your sodium and potassium levels in some cases. And they wanted to see 3 blood pressure readings taken over 3 days. And sometimes they still ask for that in situations where pilots have what's called white coat syndrome. And I'll kick it back to Jonathan in a minute. He can explain that. Now, much, much, much simpler. Since the CACI program, and for those of you veterans who participated in our webinars before, the CACI program, conditions that AMEs can issue, that's the acronym, CACI, now includes hypertension. Even though hypertension was certifiable in the office, it was an issuable condition. Prior to that, the FAA, when they started this CACI program, added hypertension, I guess as an attempt to simplify the process. So there is a worksheet, and we'll talk about worksheets probably throughout the course of the evening here, because the FAA is really trying to streamline, if that's the word for it, many of these conditions that actually used to require a special issuance, but now can be office issued by the aviation medical examiner, provided you meet certain criteria. So there is a worksheet. However, all you really need from your treating physician is a quick office note, a quick letter from your treating physician stating what medications you're taking, how long you've been on them, the dosages and frequency of use, and then have them record 1 blood pressure reading in the treating physician's office. You take that letter or the CACI worksheet, which is completed, can be completed by your treating physician. It asks for the same information. So whichever is easier, you can do either one. Take that letter with you to the aviation medical examiner when you show up for your physical, and if your blood pressure meets the acceptable limits, and here's the catch, and we'll talk about regulatory medicine and clinical medicine here, but for regulatory medicine purposes, the FAA will allow certification for a blood pressure as high as 155 over 95. And I can see Jonathan's eyes rolling back in his head now, aghast that the FAA lets pilots fly with blood pressures that high. But that's the policy limit. Your doctor is not going to be happy at 155 over 95. That's why you're going to be put on medication. So as long as you're below that limit, you're not having any adverse side effects from the medications, then the AME can issue your medical certificate. It's a normal duration medical for 3rd class. It's good for the full 2 years, and then each year, every time you renew your physical, that is, they just ask you for that same updated information just to make sure you're on the medication still, or if you're on new medications, because medications lose their effectiveness over time. Jonathan may, when I kick it back to him, he may want to talk about the efficacy of a particular medication over a long term. But it's an office issuance now, so it's really, really a simple, it's medical certification 101. It really is one of the simplest certification challenges to deal with if you got that worksheet or a letter from your doctor. So Jonathan, let's talk now about how the different meds do their job. You know, there's several different groups of medications: alpha blockers, beta blockers, calcium channel blockers, diuretics, direct vasodilators. Why don't you touch on some of those and explain how those medications work depending upon the category of drug you're dealing with?
Well, I want to be cognizant of the fact that we've only got 35 minutes, and it's a huge subject.
Yeah, keep it brief.
Suffice it to say, they work in a number of different ways. They either work to diminish the amount of fluid circulating, and if you think about this from a plumbing perspective, if you've got too much water, if your water pressure is too high in your system, one of the things you can do is drain the tank, right? You can drain some water off, and then if you do that, so you open a hose, a hose spigot somewhere else in your house, then the pressure in your other faucets is going to be reduced. In the old days, instead of using diuretics that made you pee more and get rid of your excess fluid, they would apply leeches to treat what we call dropsy, which was heart failure due to hypertension, too much fluid on board. Then there are these drugs that interfere with signaling to blood vessels so that the blood vessel wall dilates or expands and becomes a bit more floppy, so that reduces the pressure. Or it changes the way the heart works, or it works on the hormones within the body that control blood pressure. This is an amazingly complex mechanism, the way that our hearts work. And by the time you have clinically significant hypertension, already damage has been done to your end organs. So I plead with you, if you look around these United States, the current generation of kids are going to have a shorter lifespan than their parents because of the crappy diets people eat. And, actually, just to go back to something else Gary said, and in fact, I've just noticed we've had a couple of questions about it, white coat syndrome. Does anyone here, you can't answer me, but it's a rhetorical question, do you know the difference between tragedy and comedy? Well, I'll tell you. Comedy is, I watch you get eaten by a lion. Tragedy is, I get a sliver in my finger. What happens to me is obviously much more important than what happens to someone else. I get white coat syndrome. I just had my medical just a few weeks ago, and my blood pressure normally runs at about 110/65. And I knew that if I go into the office, it'll be way higher because, I'm anxious. Is my good friend Dr. Sager going to find something I don't know about? So what do? I get to the office 30 minutes before I'm due to be seen. And I sit in a chair and I just close my eyes. I don't fall asleep so he doesn't think I've got sleep apnea. And I ask if I can go into the office 10 minutes before I'm due to be seen, and I lie down. And I just do some breathing exercises, and I think of, I listen to a relaxing tape, and my blood pressure comes down to normal levels. You can always ask the doctor, could you please check my blood pressure again in 10, 15 minutes? And they'll do that for you, as long as you haven't scheduled to be the last appointment of the day.
Good tips, excellent. And you have segued us into the next common medical condition, coronary artery disease, Jonathan. So take it away and let's talk about that.
Well, again, of the people who are on this call, the likeliest thing that's going to put you in a pine box is coronary artery disease. It is rampant. And we have for a long time known that smoking, lack of exercise, and being overweight are risk factors. And we know about diet, and it's now become evident it's not just about fat, it's about sugar. Sugar consumption in the United States is, and in fact most of the Western world, but especially here, is through the roof. We know that taking sugar increases your risk list. What is this? This is a narrowing in the arteries that supply blood to the heart muscle, oxygenated blood so that the heart muscle can work. And you basically get something called atheroma, which is a fancy word for porridge tumor, because that's what it looks like. It looks like porridge oats deposited on the inside of your vessel. It gradually gets narrower and narrower, like a third up pipe. Blood can't get through, and eventually this so-called plaque becomes inflamed by bacterial infection, and then it breaks apart and it blocks blood flow. And the net result of that is that the heart muscle it supplies dies. We call that a heart attack. And for many people, the first symptom that they have of a heart attack is no symptom at all. It's just a trip to the cemetery, a one-way trip to the cemetery. So coronary artery disease is serious stuff. People think it's more common in men, but in fact we're seeing more and more in women. Yes, it increases with age. I've mentioned smoking and diet. Also, what are your blood lipids like? Largely that's an issue of heredity. Have you inherited an inability to process fats? But quite frankly, even if you haven't, diminishing the amount of animal fat that you have in your diet is a good thing. And I like a steak on the grill just as much as any guy, but not every night. Check your blood pressure and know your family history. This is a really, really serious matter, and it needs to be taken seriously. And if one of the other things that I do for myself and I tell people about is to have a scan of my coronary arteries every few years. It's not covered by insurance, but I always look for a special deal. Last time I had it done, it cost me $75 or $95, I think it was. So it's called a coronary artery scan, and it's something worth considering. Discuss it with your doctor. Over to you, my dear chap. Oh, no, I'm sorry. I've got to talk about. So let's say you've got coronary artery disease. Now, how's it going to manifest itself? Well, if you've got hypertension, you know, you're already at risk for having coronary artery disease, but it might declare itself by having a heart attack that you survive, or by having chest pain or breathlessness when you exercise. If you have that symptom, get thee to a doctor promptly and get evaluated. They'll do some special x-rays and scans to look for it. And if indeed you do have coronary artery disease, by dieting and dramatically losing weight if you're overweight, going in a special exercise program supervised by a physician, maybe taking some medications, that will take care of the vast majority. But if the coronary artery disease has progressed to the point that the supply of blood to the heart has become critical, your doctor may recommend doing a PTCA, which stands for percutaneous transcoronary arterioplasty. Basically, they put a balloon in, stretch up the narrowed vessel, and maybe put a stent. And a lot of people spell it stint, but it's stent with an E. And that's basically a wire cage that holds the blood vessel open and allows blood to flow through. Some of these stents are coated with a special drug to stop the coronary artery narrowing back down again, which can happen. Alternatively, you may go see a cardiac surgeon who will crack your chest open and bypass the blocked artery, either with a piece of vein taken from your leg or with an artery taken from the inside of the chest wall. Less and less of these so-called cabbages, which stands for coronary artery bypass graft. You'll now see why we love our abbreviations. More and more are being done by the less invasive balloon angioplasty route.
Good commentary. As far as what the FAA is going to require from me when you had treatment for coronary disease, first of all, coronary artery disease is one of the mandatory 15 disqualifying conditions. And the regulation says that it's a history of coronary disease that has required treatment, or if untreated, has been clinically significant. And there's lots of terminology and definitions in there, but next time we do a special issuance webinar on cardiac, we'll get into the details of that. But treatment relates back to that last slide. Your doctor may put you on medication and an exercise program. Technically, that's treatment for coronary disease, but it's still a reportable condition to the FAA and does require special issuance. So here's what you need, and all that you need initially. When the FAA says they need to see medical records, particularly your hospital records from your from your stay in the hospital for a stent or bypass surgery. They don't need every scrap of paper that that hospital admission is going to generate, and it will be bukus of records. You got nurses' notes, and you got your input and output and what you had for dinner and how much fluid you've had and how much you peed. All of that is really not necessary. The key things that the FAA needs to see are the admission history and physical. That's the report that's dictated by your treating physician when you're admitted to the hospital, which explains why you're in the hospital in the first place. All the procedure reports, if you go in for a stent or a bypass surgery, you're going to have a cardiac catheterization done first. So they'll want to see the cath report to find out just the extent of the coronary disease that's present, and they'll be looking at that after your procedure is done to make sure if you did have to have a stent, all of the affected arteries that were clinically significantly diseased were treated appropriately. And then finally, you'll need the discharge summary, which is the report that lets you out of the hospital. Then, after the requisite waiting period, which is either 3 months or 6 months, depending upon whether you have a stent or you have bypass surgery, you're going to need to do a maximum exercise treadmill stress test. It's called the Bruce protocol. That's the established protocol that's been around for eons. Jonathan, you probably know who Dr. Bruce was. I'm assuming it was a doctor who came up with the original protocol. The Bruce treadmill protocol has been around for many, many, many years. So the FAA likes to use things that are tried and true. So that's why they asked for the Bruce protocol. Other protocols are acceptable, but in the world of regulatory medicine, it's always best to do what the FAA is comfortable with, because they look at thousands and thousands and thousands of cardiac revascularization cases every year for all classes. So the docs at FAA are very, very good at assessing people that have had coronary disease treatment, and they're looking for very specific things on that treadmill test. One of the things they want to see is your exercise duration. The Bruce protocol is three 3-minute stages. So 9 minutes is the completion of the Bruce protocol. So you need to exercise to 9 minutes if you can get there. Basically, the rule of thumb is stay on the treadmill as long as you can. You have to get to at least 85% of your maximum predicted heart rate. The FAA, again, would like to see the maximum, which is, the formula is 220 minus your age results, the resulting number is your maximum predicted heart rate. So 220 minus 60 is 160, that's your target rate. The FAA will accept a minimum of 85% of your predicted rate. So if you get on the treadmill test where you do 83%, you're going to get it kicked back. So you have to do the protocol correctly the first time. They also want to see a lipid profile, basic lipid profile, cholesterol, triglycerides, and fasting blood sugar, because diabetes is one of the comorbidities associated with coronary artery disease. So they like to see that fasting blood sugar. And if that FBS is elevated, say above 126, which is the American Diabetes Association, kind of their cutoff number for making a determination that you're diabetic or pre-diabetic, they may come back and ask you for a glycosylated hemoglobin or a hemoglobin A1C, which is a more sophisticated study that calculates your blood sugar over about a 9-week period of time, and that number is expressed as a percent. Then they want to see a current narrative status report from your cardiologist or your treating physician. And that's not something that's written on a prescription pad that says, Joe Blow pilot had a stent, he's doing fine now, and I think he's safe to fly. That won't cut it. It needs to be a narrative report that summarizes your history of heart disease, the symptoms you presented with, when you were treated, how you were treated, what type of dietary changes or risk factor modifications you've undertaken, and specifically, and most importantly, what medications you're on at the time that report is written. The medications, the dosages, and frequencies of use. And that'll satisfy probably 99% of the situations that FAA would need to see. And unless you have something that doesn't look quite right, particularly if you have a stress abnormality or a stress EKG abnormality on your regular Bruce treadmill test, then the FAA may come back and ask you for a nuclear exercise treadmill test. But under changes that the FAA's cardiology panel made several years ago, they don't for third class, they don't routinely require a nuclear exercise test. It is required for first class and unlimited second class because of the nature of their activities, including carrying passengers for hire. So that's enough in the weeds on that, but it's important, again, document, document, document. If you have all the information right up front when you go to the flight physical, the AME cannot issue you a medical certificate the first time. It has to be reviewed by the FAA and signed off with a special issuance. But in many cases, for third class, particularly on your recertification, which is an annual process, once you're under a special issuance for cardiac, it's a permanent special issuance under the current regulations. But if your treadmill test and your follow-ups on an annual basis look good, in many cases, the AME is authorized to issue you a new 12-month certificate in the office, which will save you having to send all your paperwork to FAA and then wait around 3 months or so for them to finally get around to it and issue your new certificate. So there's a little tip there if you picked up on it. Okay.
So back on. Yeah. So back onto me to talk about diabetes. It's same theme here. You know, obesity, inactivity, bad family history, and there are some racial characteristics more common in certain races than others. African Americans, for instance, used to increase with age, is associated with hypertension and high cholesterol and triglycerides, fats. And we're going to mention this in a little bit, but you know it kind of fits now. Metabolic syndrome. Metabolic syndrome is really a cluster of conditions: increased blood pressure, high blood sugar, exercise body fat around the waist, and abnormal lipid levels. If these occur together, it increases your risk of heart disease, stroke, and diabetes. I want to give you a data point. When I was in medical school in the 1970s, we were told that and that was back in the old country, in the UK, we were told there were 240 million Americans. Of course, today that number is about 310, 315. And we were told that of the 240 million Americans, 5 million of them had diabetes. And I remember there was a sharp intake of breath around the lecture theatres. We thought of these poor Americans with this terrible disease. If I told you now that with 310 million, that number has grown to around 30 million, 30, and approximately another 70 or 80 million have metabolic syndrome, pre-diabetes. It is absolutely shocking. It is an epidemic, and it's not just a little matter of having a little bit of sugar in your urine. It leads to blindness, the skin around your feet becoming diseased. It leads to kidney failure. It leads to parts of your body falling off, stroke, an increased risk of heart attack. It's a bad disease, and it's largely caused by obesity and inactivity and eating the wrong diet. Yes, race and family history play a role, and some other things doubtless as well. But the things that you can control, you should control.
Thanks, Jonathan. Okay, here's what you got to do for the FAA. First of all, an important point. A lot of people, small percentage of the total number of people with diabetes, but many of them are diabetic, but they are not to the stage of diabetes where they require medication. So if they're they're diligent and they're dedicated, they can control their blood sugar through diet and exercise. For those conditions where your diet's controlled and require no medications at all, that is a normal office issuance. The FAA still likes to see that status report and an A1C hemoglobin just to make sure that your A1C is not so high that you should be on medication. But it's an office issuance. So if you have good documentation and you're not on any medications, the AME can issue you a certificate, normal duration medical certificate in the office at the time of the exam. Now, Jonathan mentioned metabolic syndrome. We talked about khakis a little bit ago. There is a khaki out there now called the pre-diabetes khaki, and it includes these conditions: metabolic syndrome, impaired fasting glucose, insulin resistance, glucose elevation, and polycystic ovary syndrome. Those are all sort of under the umbrella of diabetes, but they are allowed an office issuance by the FAA. There's a worksheet for that, and all these worksheets are available on the FAA website, and we link to them off of our information in the medical certification area of the website. That's found in the pilot resources section off of the homepage of our website, AOPA.org. So there are specific things that the FAA requires for that office issuance to take place. The two key things are that you, if you're on medication, you can be on one drug only called metformin, which is a very, very good medication used for quite a number of things, actually. You have to have an A1C of less than 6.5%. We talked about A1C a few minutes ago. It's expressed as a percent. 6.5 is the cutoff for that. And you have to have a fasting blood glucose of no higher than 126. So if that criteria is met, the AME can issue you a certificate in the office, normal duration. However, if you do require oral medications other than metformin and don't otherwise meet the TACI criteria, you can still get a special issuance medical. The catch is that there are many, many, many new drugs on the market. And Jonathan, just yesterday I saw something that came out from the FDA. They have increased the box warnings for some of the new drugs, the sodium glucose cotransporter inhibitors, that the FAA looked at quite a bit when they first came out and determined that they were not going to allow those specific medications because of the mechanism of action for those medications that were causing some acute renal failure. So there are lots of choices in the oral medications out there right now, but you need to look at our website and look at our medications database, or give us a call if your doctor wants to put you on a medication, because you want to make sure it's one that the FAA is going to allow. Then that A1C hemoglobin again, the FAA allows, again, for regulatory medicine, an A1C of up to 8.9%. That's pretty high. Your doctor's not going to be happy if you're on meds and still at 8.9. But for certification, you can still get a medical certificate at that level. But if you're well-controlled diabetic, Jonathan, what do you say, around 6 to maybe 7.5% would be in the ballpark of pretty decent control?
Yeah.
As A1C is concerned. Yeah.
Yes.
Okay.
Yeah.
So
lower end.
Right.
Yeah.
Okay.
So let's come on to stroke, or TIA. TIA stands for transient ischemic attack. Ischemia is the medical $100 word that means lack of blood. A transient ischemic attack is where you suddenly have a lack of blood supply to the brain and it causes symptoms. Very often something called amaurosis fugax, which means fleeting blindness. That doesn't sound too good, does it? A stroke is just like a heart attack, only in the brain. Basically, a blood vessel becomes blocked, or a little bit of gunk gets flown off from somewhere else in the body, usually the heart, and gets sent up into the brain, and as the vessels get smaller and smaller, it eventually gets blocked. Strokes are caused by hypertension. Well, we've talked about that. Coronary artery disease, diabetes. And what do those things all have in common? Poor lifestyle choices, poor diet, obesity, and not looking after yourself. If it was your aeroplane and, someone said, well, you don't need to change the oil, you don't even need to check the oil, you wouldn't be surprised when one day you're on climb out and 300 feet above the ground, there's a horrible grinding noise from the thing in front of you. We all know what a propeller does, right? A propeller is there to keep a pilot cool. We know that because when the propeller stops revolving, the pilot starts sweating. Simply put, all these conditions are caused by, very largely, lifestyle choices. So try to avoid them, and then you won't have to deal with all the FAA stuff. So basically what happens with a stroke is a part of the brain is impacted with a lack of blood, and the part of the brain that is so affected dies, basically. The range of symptoms that can occur is enormous, because it depends on which part of the brain is affected. It might be movement, it might be comprehension, it might be speech, or if it's a large enough or critical enough part of the brain, it might be inheriting 6 feet of undesirable real estate. If you have a TIA, or you think you may be having a developing stroke, the sooner you can get to hospital, the higher the likelihood that doctors can do something about it. the time interval for a stroke or a TIA is much smaller than it is for other areas of the brain, because other areas of the body, because the brain is so sensitive. But we can do similar things that we can do in the heart. We can put catheters in, dissolve clots, pull clots out, and if necessary, do surgery to try and improve the blood supply. There's a little acronym that you should remember. You should act fast. Just like in an aviation emergency, in a medical emergency, you should act fast. F stands for face. If you notice that a side of your face, or anyone notices a side of your face is drooping, it's become weak, or that you can't close your eye properly, or that the corner of your mouth is dribbling, that could be a sign of an impending stroke. If you have an issue with arm movement, you have some weakness in an arm or a hand or a foot or a leg, that's the arm. The third, the S, is speech. If you've got any problem either understanding speech or articulating, get to a hospital fast. The final letter T stands for time. The faster you get there, the higher the likelihood of a successful outcome.
Excellent, Jonathan. So, the bad news for people that have had a stroke or TIA is the recovery period, because the FAA requires 2 full years, in the majority of cases, 2 full years of recovery before they will even consider you for recertification. There's a risk for recurrence, particularly with the TIA, because if you have a TIA, then that increases your risk of having a full-blown stroke down the road. So the FAA, being the conservative animal that it is, wants to see enough time go by with good recovery and good follow-up to put them at a level of comfort that you're not likely to have another event. So once the 24 months is up, they'll want to see all your basic treatment records, your hospital records, what was done to take care of the stroke. They will need a current neurological evaluation, so you got to follow up with a neurologist. Neuro evaluation is basically a fancy office examination where they check your reflexes and they check your different nerves and evaluate you for any residual symptoms that may be present from the event. However, in recent years, the FAA has become more likely to also ask you for a neurocognitive evaluation, and that's a pretty involved assessment that usually comprised of a battery of tests done by usually a neuropsychologist, psychologist or neuropsychologist, that evaluates different areas of brain function, executive function, decision-making, short-term, long-term memory, recall, those types of things. It's a fairly involved assessment. It used to be that the FAA would say it may be required, and I believe their AME website, the AME guide online, still says neurocognitive assessments may be required, but we're seeing them being routinely asked for just about everybody who has had a stroke or a TIA. Again, it's a fairly comprehensive evaluation, and it does take some time. And the problem with the neurocognitive testing is there's no baseline for that. If everybody that wanted to be a pilot went out and had neurocognitive testing as a baseline, and then they had an event 20 years later, they could go back and look at your baseline and see if you had the same deficiencies prior to the stroke. Unfortunately, that data doesn't exist. So the neurocognitive assessment is, in some specialists' opinion, is a little spurious in the amount of sophisticated data it gives to the FAA as far as risk assessment and decision making for medical certification purposes. But that's the way it is. Okay, Jonathan, you want to talk about sleep apnea?
Yeah, I was just getting my phone off of mute. Sleep apnea basically means you don't breathe when you sleep. It's bad. And surprise, surprise, sleep apnea, the most common form, obstructive sleep apnea, once again, is most commonly found in those people who are overweight. And you can see that it's very prevalent in the United States population. It has become more so with the obesity epidemic. No surprises there. Some people have sleep apnea without being obese, But one thing I can tell you is that the bed partners of the people who have sleep apnea, because one of the things they suffer, because what happens when you have sleep apnea is you snore. And you'll notice there's a little symbol there, a key, and it says 70% of people who are obese have sleep apnea. The key to that lady's heart, right? Please cure my bed partner's sleep apnea. It's a bad situation.
We had a discussion in our rehearsal.
Yeah,
go ahead, Jonathan. I'm sorry. I didn't mean to interrupt you.
No. You go ahead, Gary.
Well, the key symbol, that little icon that showed up in the previous slide, we had a discussion about that yesterday, and Jonathan very romantically came up with his determination about what the key really means. So moving on.
Yeah, indeed.
Go ahead, Jonathan.
So there are a number of things that comorbidities or risk factors. The risk factors or the indicators, if you have sleepiness during the day, if people have noticed personality changes, some aggression, impairment of your cognition, you're overweight, you have a thick neck, your mandible is kind of a little bit backwards, if you will, and certainly the architecture of the soft tissues inside your soft palate at the rear end of your throat. But again, this is serious stuff. People say, well, it's just I'm snoring. I don't see why I've got a problem with the FAA. If you've got sleep apnea, you are at increased risk of falling asleep at the yoke, and we've heard of pilots doing this, right? It's not like this hasn't happened. If you have sleep apnea, you have increased risk of stroke, increased risk for thrombosis, high blood pressure, enlargement of the heart and dysfunction of the heart, increased risk of coronary artery disease and disease of the arteries in your neck leading to stroke, and you have an increased risk of death. It's very, very serious, and it needs to be taken seriously.
Yeah, good points. And that's why the FAA a few years ago came out with a policy. They were actually encouraged to do that based on accident investigations from the National Transportation Safety Board, and I think Congress may have had a hand in that as well. But the FAA came up then with a policy and really began to emphasize the significant risk factors associated with sleep apnea, which is at the very beginning of the webinar tonight, we use that example of the AME asking the airmen questions regarding sleep apnea, because it is mandated now. The FAA is super serious about this, and the policies are in place to screen for sleep apnea and get pilots appropriately treated so that they can maintain their medical certificates. So the guidelines, and you can go out and look at these on the AME guide online. It's a public document. It's a little clinical. So if you're really comfortable wandering around in clinical medical jargon, you can take a look through the guide and look at the resource material that's linked off of the FAA's pages. This is a fairly exhaustive evaluation and policy change that FAA made in, I believe it was 2013. But for those who are well treated, the FAA wants to see the original sleep study that led to the diagnosis. They want to see just how bad your apnea was. That's usually depicted by the AHI, the Apnea Hypopnea Index, which is basically a scale that determines how many apneic events you have during the period that you're being monitored. And the higher your AHI, the more serious the sleep apnea is. They want to see, obviously, they want to see good evidence that you're treating your sleep apnea appropriately. And CPAP, continuous positive airway pressure, is really the most commonly prescribed treatment modality, and that's really the one that provides the FAA the best assurance that you're getting adequate sleep, because the newer generation machines actually have a computer chip in them, and they monitor your compliance data and your utilization. And you can pull that chip out and take it to your sleep study. In some cases, you can do it on your own computer and create a report that you can provide to the FAA that shows how often you're using the machine and how much sleep you're getting each night. So the FAA's guidelines are that they would like to see you be able to be using the machine at least 75% of nights. and they like to see that you're averaging somewhere around at least 6 hours of sleep per night. There are other treatment options available, and Jonathan, you might want to chime in on the UPPP surgery here in a moment, but CPAP generally has the best outcomes. Last September, I was at a medical meeting down in Fort Worth, and one of the representatives from the company called Somnodent, it's a dental device that now has the capability of generating a report. And the FAA, in their specification guidelines for sleep apnea, indicated that they would be willing to consider one of these oral devices, a dental device, once the technology got to the point where there was adequate ability to document the utilization and efficacy of the device. So this, I believe it's called Somnodent, is actually an option now. I've talked to only a couple of pilots that are using that, and it seemed to be working well for them. But you know, sleep apnea is a spectrum disorder, so some people have more severe cases of it than others. So whatever is the best treatment and the best outcome for you is what the FAA will allow. But the CPAP generally is probably going to be the best choice for most pilots. All right, we have covered a lot of material tonight in an hour, and we just scratched the surface. Again, for those of you who have been with us on previous webinars, we can talk for hours, literally, about the subjects that we cover in a webinar, but unfortunately, everybody would fall asleep, and you know, it just wouldn't be a very good webinar. But we'll be doing more of these, but we want to summarize here just a little bit about what we talked about tonight, just to reemphasize the importance of these key things. Know what your medical condition is and know how the FAA is going to handle it. Call us. Again, we have a dedicated staff here in the PIC, and we would much rather help you at the very front end before you get involved with the FAA, so we can get you off on the right track, make sure you have the correct information. The delays right now at FAA certification are running in excess of 90 days, 3 months. So if you start out, you know, in March, expecting you're going to be flying in the spring weather, you may not make it if it's a condition that does require special issuance. So plan ahead, just like you plan a flight, plan your next medical, and call us if you have any questions, and we'll help you get off on the right foot and minimize the amount of delays. Have that good documentation with you. We didn't talk much about AMEs tonight in the context of, you know, some AMEs are great. Some AMEs are, yeah, they're okay as long as you don't have a problem. But some AMEs just don't like to deal with the problem cases, the special issuance cases. So if you have one of those AMEs that's willing to work with you on it and you have good documentation, in a lot of cases, if there's a question about it, the AME could pick up the phone, call either Oklahoma City or the regional flight surgeon in the region where you live, and in some cases they'll get the okay to issue the certificate and then forward the paperwork on, and then the FAA can review it and get back to you. So use all the options that are available to you and all the shortcuts to get you your certificate the fastest time possible, because the last bullet there, if you get deferred, you're going to be delayed, and there's really not much anybody can do to speed up that process if you get deferred. So the best way to avoid a delay is just don't get deferred and have good documentation when you go in. Okay, it is now 9:03. That was a fast hour, Jonathan. Hey, thanks so much for joining us, Jonathan. Thank you. Your wisdom and your input is always welcome. Everybody have a great evening. Thanks to Joanne again for handling the questions tonight. Have a great evening. Good to be with you, and give us a call. Hey, we'll see you next time. Bye now.